Hello, everyone. Saturday, it's our meeting number 5 in this year in our fellowship program. Today, I have the honor to be here, Dr. Constanza Perez from Chile. And Constanza, how are you? Everything okay? This early morning in Chile, I think it's 6 morning.
Hi, it's 7 a.m. It's okay. Everything okay here.
Uh, Okay, great. Constanza, tell us what you will discuss in your oral presentation for this month.
Today we will talk about a little of IOL sutureless scleral fixation. Of course, Yamane is the most known one, and we will talk about some other modifications that have been done.
Great. So for everyone that's watching us, having here with us this morning, you have the Constanza presentation, and after you discuss about OPD, about aberrometry, and at the end you go for our private room to discuss the fellow's case. Constanza, if you are ready, let's go.
Thank you very much. I will share my screen. Please tell me if you can see it. I'm sorry, 1 second. Here, can you see the presentation?
Yes, perfect. You can start.
Okay. As Dr. Sergio already said, I'm from Chile, and today we will review the topic a little bit about sutureless scleral fixation of IOLs. Today has become much more popular every day and has had various modifications from the beginning of this technique in 2016, when they used, for example, glued IOL, until the Yamane techniques and many other modifications that have been done to the date. It's designed for cases in which there is it is not possible to implant an intraocular lens in the back, so you have to look for other options. This kind of surgery, it has the advantage that it's really easy to combine with other types of surgery that wasn't possible before, like, for example, a penetrating keratoplasty or a vitrectomy that was really difficult before with other techniques. And these techniques, all that I will talk today, have better techniques. They are closed chamber manipulations. They have better instrumentations and have refined it and make it more predictable results, more repeatable results, more quick surgeries, among other advantages. The first one that I will talk about, it's the first that was without sutures. It was by Agarwal and collaborators in 2007. It is the glued IOL. It consisted, as you can see in the pictures, at the beginning they do a mark 180 degrees apart from each other, and they created an intrascleral flap of 2.5 by 2.5 millimeters, and they use that was centered on the pupil. They used then 2 straight sclerotomies inside the eye with a 23 gauge needle, approximately 1 to 1.5 millimeters away from the limbus. In that sclerotomies with an end gripping forceps, they took the haptics away from the eye. You can see it in here in the last picture of the top to the right. After that, they did an intrascleral channel parallel to the limbus with a 26 gauge needle, and they stuck the haptic in there, and at the end they glue it with fibrin glue, the flap and the haptic, and they seal it. Then they close the conjunctiva, and that was the surgery. After that, there was a change, a very big change, and in 2014, Yamane described for the first time his technique. At the beginning, he used a 25 gauge trocar, but then he changed to needles, and I will show you then the modified technique that he used. He published in 2017. And here you can see a quick video will show you how he marked the limbus 2 millimeters away, and he put the lens inside the eye, and he did 2 intrascleral tunnels with a 30 gauge thin wall needle. Then you have to dog the optic into the needle, and then you do the docking of the second haptic into the needle in the posterior chamber, of course. Then you will see how he takes away both needles. Some people do it one needle first and after the other one, as in this video. The original Yamane paper described the two haptics being thrown away of the eye at the same time, and then he's cauterizing the haptics, and you can see there that that's the flange creation, and then the importance of putting the flange in the intrascleral channel. Sorry. Therefore, you can see as these techniques. I will keep on. Sorry. This one is from the paper of Yamane, the original one. At the beginning, you can see a picture of the same thing that I show in the video, how he does it. In here, he used some retinal trocars to maintain the chamber, and the same that we talked already, and the importance of the creation of the flap. It's really important in this technique that there is no conjunctival dissection, nor flap creation, and that means that it is much less possible that we have a wound leak in the post-operative, much less chance to have a leakage and hypotony, though reducing the risk, much less scaring also. So in this work, Yamane shows us his results. Here you can see the best visual acuity, the corrected one and the uncorrected one. And you can see that with a mean follow-up of 20 months, and you can see even up to 36 months, he operated 100 eyes. And you can see that the visual acuity is really good, the corrected and the uncorrected. And also you can see as the cell density of the endothelial cells, it's really without very much significant change during the time. And this was a really big change with other fixated lenses, secondary lenses, like, for example, the iris fixated lenses. Here are the lenses that he used. He used 4 different types of lenses to try his technique, and he showed really no much significance in the refractive difference. But it is important to see that there is a new complication or a different complication of this technique. There was the tilt of the lens that was really important, and the capture of the iris also. Okay, so this is one of the things that we will talk about most in this presentation. And with the post-operative complications of this technique, you can see it's really similar to other kind of lenses that they have been used to the time, like vitreous hemorrhage, hypotony, IOP elevation, and corneal edema. And late complications, the iris capture of the IOL, cystomacular edema, and IOP elevation was described. He didn't describe any endophthalmitis in his studio, but we know that, for example, if you leave the haptics not in the scleral tunnel, not stuck enough, or showing it is a risk. So I will tell you some pearls in these techniques, but sometimes you can see it's everyone talks about these techniques, but it has some important things that you have to do that will help you do it all right, because otherwise you make too much haptic manipulations and it doesn't work. There is too much tilt of the lens, and you can manipulate too much the eye. So it is really important to mark 180 degrees apart from each other. It is recommended if you use a toric marker to do so. You have to do a vertical T position between the corneal incision and the places where the haptics will be grasped through the scleral. If you remember the video where the lenses come inside and the 2 sclerotomies that were made, there was a vertical T position, and also how he took the haptic to manipulate it. That will make it much more easy. So another big question they use is, which IOL can I use in this surgery? Actually, there have been some time and some more experience than when Yamane did it, when he published it, of course, during the time. And now we know that ideally we have to use PVDF haptics. And with that, the lenses that were more used is the Zeiss CT602 and the Sensor AR40. It is easy to make the flange, it is more stable in time, and has less tilt. Another big thing is that it is described that they use a 30 gauge thin wall TSK needle, but it's really important that it is a thin wall needle. It's not any 30 gauge needle. If you don't have it, it is recommended that you use a 27 gauge needle. Okay, it's more secure, so you can stuck the haptic into the needle without any big risk that you cannot fix it inside the eye. Okay, that is important because in many places they have a 30 gauge without thin wall. Another technique that has been described, or they describe, is that you can insert the first haptic directly in the needle lumen. And then the second haptic, as described by Yamane with the retinal forceps. That is kind of difficult depending on which injector you have for the lens, another soft. The other option is do it like Yamane with both retinal forceps, with both haptics, the docking with retinal forceps. And the last thing is the importance of the flange. We will talk about a lot about that because it is proven already that it's one of the most important things in the IOL stability and the fixing force that you will have later in time with this technique. So we have some papers, some works that have compared it with an IOL suture, this technique, and it has proven much better in time. It is less postoperative astigmatism. They describe, otherwise you can find some different opinions in that, but in these two works, they describe that there was no difference in the rate of tilt compared with the glued IOL, the one that I showed you first. And there was a significantly shorter surgery time. That was one of the best things about the Yamane technique. It was much shorter, 20 minutes approximately compared with almost 50 minutes with the glued IOL. So if we talk about a little bit about IOL tilt and decentration, that is one of the biggest problems of this technique. I will tell you that some things are really important to avoid it. That is the careful creation of the intrascleral tunnels. They have to be similar. They have to be long intrascleral tunnels of similar length, 180 degrees apart, as I have said already. You have to avoid extensive haptic manipulation, and this is one of the most difficult parts for the beginners in this technique, because sometimes the docking is not so easy. And the proper haptic flange creation, as I said before, those are the three things that you have not to forget to prevent the tilt and the decentration of the IOL. As I said before, the importance of the PVDF haptics is that they have better memory of shape. They do like a mushroom-shaped flange when you cauterize them. And there is some resistance to deformation and kinking that it's much more than with the PMMA optics of other lenses. And this is important. Why? Because the tilt and the decentration can lead to significant refractive error, to astigmatism, high-order aberrations, a patient that is really annoyed with his vision and it's really bad vision, and decreased contrast and glare. And the problem is sometimes as big as you can see in this picture here at the bottom. In the left side of the image, you can see just the postoperative. They were finishing the surgery. It was a surgery with no problems described, normal surgery. It wasn't with much manipulation or anything. And you can see a good centration, stable lenses. Then in the middle, you can see day one postoperative. Not 4, not 1 week, not 1 month. It was day 1. It was really, really fast. So they decide to explant the lens, and then in the right, you can see there is the two parts of the lens at the bottom. It's a little bit difficult, but they are up there. There is the optic of the lens, and then you can see the haptic like 90 degrees away from where it's supposed to be. So as I said, one of the most difficult parts is the needle docking and the management of the haptic. It's technically difficult. For the beginner, it's sometimes they manipulate it too much, they break too many haptics. So it is important, and also for not beginners, it keeps on being one of the most stressful, I will say, moments of the surgery. So it's important to optimize the positional relationship between the haptic and the injection needle. It's one of the biggest mistakes. And as this is the most difficult part, or one of the most difficult parts, it's one of the most that has most modifications. Of course, they have tried to make it easier. In that, Kim and collaborators are the ones that have made most different approaches. And they reported first a method of when they pull out the leading haptic, the first one, through a corneal incision, and they do the docking first of the trailing haptic, the second one, with a needle. And then they keep on doing with the first one. why they do that? Because the trailing haptic is the most difficult haptic for the docking of the needle. So they said, let's start with the most difficult one, and then it will be a little bit easier, and then we'll change to the first one. Okay. Then Najafi et al. Reported also a method to do the docking with a wide viewing system for vitrectomy. The problem with that, it's easier to see it, but it's not really available in all hospitals or in all countries, to say so. There have been many other modifications. Some people reported created scleral tunnel with vitreous trocar, but that is much more manipulation of the sclera and the manipulation of the haptics with trocars rather than with needles, making it a little bit easier to manipulate, but also a bigger tunnel, a bigger risk of leakage. Other modifications that we can see is fixating the leading haptic first, which avoid the needs for an assistance on any other special device to hold the first needle during the docking of the second needle. This is called the single needle modification. Actually, that is what we saw in the video, that we do the docking of the first one, we take it out, we do the flange, and then we take care of the second one. Okay. They also reported a flattened flange that was really easy to do using a needle holder. You flap the flange, and that is described to increase the haptic stability. Another studies propose that the approach normally is described as a superior approach that has to have a flange that is nasal and temporal, as you saw in the video. But they propose that you use a temporal approach that use a superior and an inferior flange, like this, something like that. Why is that? Because they say that the vertical corneal diameter is typically much shorter than the horizontal corneal diameter. We think so. It has a lot of logic, I think, to me. Because normally the horizontal diameter has 12.5 or even more. And if you think that a normal three-piece lens has 13 millimeters, and the horizontal diameter has 12.5 millimeters in wide, when you add to that the size of the scleral tunnels that you make, you have a really tense optic junction of the optic and the haptic. You make a lot of stress to the lens and to that part, the junction of the haptic optic. Okay, so if you use the vertical diameter that is 1 millimeter shorter, in average, it will be much less stressful for the haptics and for the joint. Okay, and the last modification that we're talking here is the trimming haptic techniques. That what they did was cutting the haptics 2 millimeters outside the eye, and that left for an easy manipulation when you're inside the eye. You have a shorter haptic when you do the docking. You can see that normally you have a bend of the haptic like this when you do the docking. If it is shorter, it is much easier to manipulate and get straight into the needle. They say that there is no more stress in the optic haptic junction. That is what they say. Some other papers think that when you cut them, you make more stress, but it is used that sometimes people outside the eye, they cut them too. I could not talk about Sutureless scleral fixation without talking about Dr. Sergio's work. It is really groundbreaking in this area. I could not explain it like him, but I will try to explain you a little bit of this technique. The first, he described the double flange technique that was for a capsular tension segment for the management of sonular dialysis, not for the implant of a secondary lens. But it is important to talk about it. And first, he removed a haptic from a three-piece polypropylene IOL. And it is called the double flange because it makes two flanges, as you can see in here. One that is tensing or docking, to say so, the capsular tension segment ring, and the other one that is goes into the sclera, and the other one is fixing it, docking it, fixing it in the scleral tunnel. Okay, and then he changed it and into a Prolene 5.0 because it was the same material than the haptic, but much more easy to manipulate it. And then he developed the flange IOL fixation technique. It was described to use a 5.0 propylene suture, but also depends in which lens do you have. He also recommends a 6.0 propylene suture to use it. And here you can see how you have the importance of this technique is that you use a 4 eyelets IOL, and then you can see how he goes. Here is one scleral tunnel. He goes in here one of the eyelets and out in the other eyelet, and then out in another intrascleral tunnel. The same on the other side. Normally, he has 2 flanges. He first cut it here in the propylene suture, the first 2 in the bottom here. He cut it, he fixed it, he makes the flange, and then he managed to stabilize the IOL, make it where it should be, and then cut the other 2 flanges, and then you have the 4 flanges, as you can see here in the picture, with a really good stable, really less tilt. And I would say that the polypropylene is much easier to manage than the haptics of the IOL in the other technique described. The problem, I have never tried this one, that's why I'm saying, because we don't have in Chile the 4 eyelets, any 4 eyelets IOL. There are other modifications that have been described, similar with piercing of IOLs if you don't have 4 eyelets IOL. But it's also difficult, and there has been described that you can break the IOL and some tilt in the long term. So in conclusion, when we have a patient that is in aphakia and you have to do a secondary intraocular lens implantation with no support, it is still a unique surgical challenge for all of us. We have to think in every patient what we can offer, what we have, what is best for them, depending on how many surgeries we have the patient has had before. That's really important. How is the sclera? How is the conjunctiva? How is the retina? So this kind of patients, it has become really difficult to be in front of. But every day we have different techniques, more refined, more minimally invasive, more options to offer them, more options for us to manage. And this has opened a new field because it has a lot of different modifications and advancing research. These surgeries that I have talked today have much less endothelial cell loss compared to anterior chamber lenses, for example. It has less pigment dispersion syndrome. It has been described less uveitis glaucoma ephema syndrome, less macular cystoid edema. So it has been a really good advance when you compare it with other techniques that we have used before. But we also have to think still that there is no long-term follow-up. Okay, Yamane described it first in 2014. This is a really new technique that is in use, and I hope we can see more in time, more modifications. It is more available for patients to offer to them, more stable in time. I hope that every day that passes, we can offer a new option for these challenging cases. So thank you very much for hearing me. I will stop sharing my screen.
Constanza, congratulations. Really, really amazing lecture about scleral fixation, no sutureless scleral fixation. You did amazing research about the topic. You discussed Amar, you discussed Yamane, you discussed the 4 flanged. And I'm sure that everyone that watched your lecture are happy now because you did an amazing synopsis about it. You said perfectly. It's important to pay attention in that point that you said. Scleral fixation is not an easy technique. Any scleral fixation is an easy technique. You need, I suggest every fellow, every colleague, if you start in the scleral fixation world, you need to do a wet lab, a dry lab. You need to try before to go to the eye to the patient. It's important to try with a experienced doctor in your side, the first case. And don't do scleral fixate one time a year. You need to be the reference in your hospital, need to be the reference in your city, because if you perform only one time a week, no, sorry, one time a year, it will be really difficult. Congratulations. Any comment you want to say about your presentation? Because I really like it. This is high level. You can present it in ASRS, ESRS. You have a good level your lecture.
No, thank you very much. It's really important what you said to practice before, because you have done the docking. It's really, for me, it's the most difficult part, I would say. It's it's easy to
Yeah,
damage.
about tilt. About
And
tilt. Yeah, the
it's,
tilt is important because these are, I prefer scleral fixation with 4 points because 2 points sometimes you have more tilt than with 4 points. It's your opinion too.
yes, yes. But I have never tried. We don't have the IOL, for example, the any four eyelids. I hope that it arrives soon to Chile. Please send one, so we can try.
Constanza, you are approved.
Thank you.
You are approved. Now, remember, this is the same topic that you write your chapter to finish your receive your certification at the end of the year. Ladies, guys, let's go to the Google Meeting room. Let's discuss the about how to select the best IOL for a patient. This month was amazing, and you answer the questions. Okay, Constanza, any comment to add?
No,
No,
thank you.
thank you. Amazing presentation. See you in 2 minutes.
See you.